know you could hear us okay. Let's see. Everybody can hear us okay?
Yes.
Okay, fantastic. Thank you. We're today going to talk about COVID-19 update as of October 2020.
Yep, I'm Dr. Horn.
Dr. Reed.
And it's nice to have a webinar and talk to everybody again. I think this is a great topic to give updates. You know, we haven't done information on updates lately, and I think it's really good to do. I think you know, it's nice to have everybody on the same page and what we're doing, what others are doing, and you know, I think it's a great topic for all of us to talk about.
Yeah, and I know we got a lot of good questions for today's webinar too, so we'll make sure to address them as well.
And if you have any questions for us, just go ahead and put it in the chat as we go along, and then we can kind of go from there. Okay, and so where do we get our information? We get our information from NIH, and so the NIH recommendations are what we follow, and we like to stay very mainstream and do what's recommended through the NIH, so we know we're giving the proper care.
You know, before we didn't have a lot of data, so there was a lot of different areas we were getting information from, but now I really like NIH because everything is there, what works, what doesn't. They have all the studies cited. It's a really good tool for all of us, and they continuously update the NIH guidelines as well. So I think it's a really good site to go look for guidelines. And if you Google, it's NIH COVID-19 guidelines.
Right, and it's very big. Okay, so like you're saying, there wasn't very much information before, but now, you know, we're looking at it's over 350 pages of information on COVID. So there's now a lot of information, and so we'd like to kind of go through and summarize the updates and the proper treatment as far as what's being said right now. And so that's what we're going to go through right here. And as far as the spectrum of infection, there's asymptomatic or pre-symptomatic. So pre-symptomatic is when they are exposed to COVID and they, test positive, but they don't have any symptoms yet. And so they either aren't going to have symptoms and going to remain asymptomatic, or they're going to have symptoms, you know, in the next few days, but they haven't had symptoms yet. So that's that category. And then there's mild illness, moderate, severe, and critical illness. And then as far as comorbidities, and people with these comorbidities have a higher risk of progressing to severe COVID. So if a patient comes in and they have a lot of these comorbidities, and they're in that pre-symptomatic or asymptomatic stage, you have to kind of look at it and say to yourself, does this person have a high risk of progressing to severe COVID? And if they do, there are some steps you can take, and we'll discuss those.
Yeah, and I really, you know, we're going to talk about monoclonal antibodies and how to give them in, you know, mild to moderate infection. And where I am seeing the opportunity that we're not giving in our community is when it's, you know, it's not as strict. The EUA for monoclonal is not as strict. And weight, BMI is a really good tool as well for our patients. And a lot of times that's getting ignored. So we'll talk a little bit more about it. And one of the risk factors, if you're any age, even if let's say you're 25, but if your BMI is elevated, that patient can get monoclonal antibody. And we're missing that opportunity in communities, because we're seeing a lot of young patients like 25, 30, 34 getting admitted and having really, really severe disease.
Right, and I'm not very strict when it comes to these comorbidities. I'm not very strict, meaning that if, you know, sometimes I'll get calls and people will say, you know, these are this person's comorbidities. Do you think it's okay to give this medication? And I think I've said yes on all of those. Yes. I think that, you know, and the reason is because, you know, if the patient is has some comorbidities that are bad but not included here, I still think, you know, I don't want to be withholding medications that could save their life. That's kind of how you feel,
yeah,
I think, yeah.
We had some shortage of monoclonal, but the supply is back now and it's good. So providers can decide individually, like, should this patient get it? But I see the missed opportunity where they're seeing young people and they're like saying, oh, you don't have any health issues, right? But when I look at them, their BMI is high and I would have given it to them. So I think it's really important to kind of each patient individually evaluate and give it.
Right. And it's tough to look at someone and say, oh, you'll probably be fine. It's kind of tough to do that and to kind of weigh those risks, because when we see healthy people dying from it, I kind of look at it and so I wish they would have gotten it. And so I kind of look at it, if it were me or my family member, what would I say? And if it were my family member, I'd want them to have it. So I have a very low threshold where I approve those things. If you, but I don't mind the calls. So anytime you want to call and say, hey, what do you think of this situation? I'm happy to say, I think it's a good idea. And then you can put in the chart, discuss with MD stewardship, and they agree, And then, so I think it's a good idea just kind of go through, and this is the stepwise. So we will go through, this is therapeutic management for non-hospitalized adults with COVID-19. So if you're seeing a patient in the clinic with COVID-19, so on the left, you have patient disposition. So what is happening with that patient, and then the recommendation.
Yeah, so this is like that mild to moderate patient, right, in our community that comes to the ER, to the clinic, urgent care visit, or calling our primary care physicians. And they have COVID-19, but it's mild to moderate. They don't qualify to be admitted to the hospital. They're not requiring oxygen. Their O2 stats are not dropping, but they have COVID-19. And in all states, monoclonal antibody is readily available through the federal government and it's free. We should be using this more than what we're using at this time. And the slide before talked about the high risk category, but the emergency use authorization currently states the provider gets to decide at the bedside how high risk this patient is. So if you see a 30-year-old and their BMI is elevated, everything else is okay, you can still give that patient monoclonal antibody. The really, really nice thing about monoclonal antibody is that if you give it within the 10-day symptom onset period, you can prevent hospitalization, prevent ICU visit, and you could prevent death. So studies have now shown it prevents mortality. So it's really beneficial. It's like earlier the better, so the patients don't end up in the ICU and pass away.
Right, and we're so far into this pandemic that we have good evidence showing that they work very well. So that's very reassuring. Yeah. So, and then here we have, the different options here. And so when you see the different options, you can decide what you have available to you and what you can use.
They're easily interchangeable. Whatever the monoclonal you have in your hospital, they all work effectively. They're all equal, so you could use whichever one you have in your hospital.
And then now also for non-hospitalized patients, this next one, these are discharged from the hospital inpatient setting in stable condition, does not require oxygen. They recommend against continuing remdesivir or steroids like dexamethasone or baricitinib. So once they're improved, they're no longer on oxygen, they're ready to go home. You don't need to keep them in the hospital to continue any of these things. You can say, wow, you're no longer requiring oxygen, you're doing so much better, and you can send them home, not on anything anymore for COVID. And then here's discharge from the hospital inpatient setting and requires oxygen. So this is kind of an interesting one because the patient's improved, but they still require oxygen. So there's insufficient evidence to recommend either for or against continuing remdesivir, dexamethasone, and or baricitinib. And so I would say it kind of depends on the situation. It depends how sick is this patient, what exactly is happening with them.
A lot of times what's happening is because the hospital is non-available,
Right.
A lot of the patients who would be admitted but not getting admitted that are requiring oxygen, they're going home on oxygen, they're still receiving steroid treatment. It's hard to do remdesivir or any type of treatment at home, but physicians are prescribing still steroids to take at home. And the reason is they're sending them home on oxygen. and they don't have beds in the hospital. So I think in those cases, that's okay.
Yeah, I think of that as kind of an exception because normally you would keep that patient in
Yes.
the hospital, but then now because of the events that are going on, they're being sent home, which may still be okay. But as far as continuing dexamethasone, you just have to kind of look at the patient and say, what would I want, and
Yeah.
what is the risk of ARDS and things like that, which you can't really calculate.
Yeah.
So
Because in my mind, right, if this patient was going to get admitted, but we didn't because of beds and staff shortage,
yeah,
and you could give them. Yeah, and then you could give them dexamethasone.
okay. Discharge from the ED despite new or increasing need for supplemental oxygen. So they recommend using dexamethasone 6 milligrams PO once daily for the duration of supplemental oxygen and do not exceed 10 days. And with careful monitoring, and I think that's important too, because dexamethasone, it's not harmless. People can still have issues with extremely high sugars and other issues. But there is insufficient evidence to recommend either for or against the use of remdesivir. But again, like you said, it's hard to continue remdesivir or start remdesivir as an outpatient.
Or vaccinated too. So
Right.
I think this is what I was touching base earlier. Dexamethasone is okay, individualized cases with oxygen if that's what we have to do.
Yep. So that was outpatient, and now we have therapeutic management of hospitalized adults with COVID. And we're going to start with hospitalized does not require supplemental oxygen. So recommends against the use of steroids for these patients not requiring oxygen. And then insufficient evidence to recommend for or against remdesivir. And then the next category, hospitalized and requires supplemental oxygen. So those are the patients that there's very strong evidence showing remdesivir and dexamethasone plus remdesivir for patients who require increasing amounts of oxygen. So that's the recommendation. Remdesivir is going to try and stop the viral replication, and then dexamethasone is trying to reduce the inflammation.
So we get asked a lot of questions. When we started using remdesivir, we were still learning a lot. And at that time we said don't use remdesivir in acute kidney injury or if you're a dialysis patient. Remdesivir is only for 5 days. So now we actually use remdesivir in acute kidney injury as well as dialysis patients. But what we have to do is make sure the patient understands the benefit versus the risk. We're using remdesivir within first 14 days of symptom onset. We're using it to decrease the viral replication. And there's a small risk that it can be harmful to the kidney, but again, benefit versus risk. And making sure patient understands that if they do, then it's okay to give remdesivir even in that population.
Right, and the issues with kidneys, I've had patients that say, what about the kidney risk? And it's really, they need to be able to survive to worry about the kidneys. And the biggest threat to them at this time is going to be COVID. So when they come in and they're not looking good with COVID, or even if they're looking okay, but they're a high-risk patient, if you're trying to weigh the risk and benefits, I always side on the side of remdesivir because it may help them live. So that's kind of my feeling about it. Yeah.
I agree with you.
Oh, and then here, this is the dexamethasone. I just wanted to comment, it's 6 milligrams once daily for the duration of supplemental oxygen. So if they're improving and they no longer need oxygen, they're going to go home, it's okay to stop the steroids and home. And then hospitalized and requires oxygen through high flow. So these high flow patients, it's going to be the same recommendation with dexamethasone plus remdesivir. And it also says if they're quickly deteriorating, they're getting worse very quickly, you can consider baricitinib or tocilizumab.
Yeah, so this is really important. I know we recently had a shortage of tocilizumab nationally. So we know dexamethasone decreases the inflammation, kind of prevents ARDS. Baricitinib and tocilizumab, so baricitinib is a JAK inhibitor, and tocilizumab is an interleukin-1 inhibitor. But they're functioning as to reduce inflammation that we get with COVID-19. And when we used to use this before, we didn't have a lot of data, but thankfully now there's large randomized control studies that show baricitinib and tocilizumab prevent death, can help with mortality in severely ill patients. So I think these two drugs, when the patient qualifies, should be used,
Right.
and can prevent mortality.
Interleukin 6.
Interleukin-1 and JAK inhibitor.
So and I'm going to say the same thing with this one. There are worries about people say, well, how do I know that's not going to give me, make me more prone to infections? And that may be true, but the biggest threat to their life at this time is going to be COVID. And we know it helps with COVID. So, we're trying to do everything we can to save their life with these medications. And, sometimes there are some patients that come in and they've, been told by their friends and they've done reading and they're worried about, side effects. And they talk a lot about side effects, but really the most important thing is fighting COVID at this time.
Yeah, if you're not severely ill, we need to be using drugs that going to be effective now.
Yeah.
And then hospitalized and requiring invasive mechanical ventilation or ECMO. Again, in these patients, we should really think about dexamethasone. If it's less than 14 days, remdesivir plus tocilizumab. So ECMO and invasive mechanical ventilation, tocilizumab is preferred over baricitinib. So we should be using those drugs as well in that case.
And another question about the DVT prophylaxis. And so this is another question we get for non-hospitalized patients. We wouldn't recommend starting DVT prophylaxis for patients that are non-hospitalized. There isn't any evidence for starting anything. We saw people do that early within COVID pandemic, but the evidence really isn't there to give someone anticoagulation when they're not hospitalized. And then for hospitalized patients, we recommend giving your standard DVT prophylaxis. And then laboratory testing, some people will say, well, are there any labs I can check? And if they have a lot of inflammation, starting something. And right now there's insufficient data to recommend starting something based on lab testing for these patients. So you would just do your standard in-hospital DVT prophylaxis for COVID patients. And what do they recommend not giving? So there are medications that they recommend for COVID, and then they recommend, not starting some medications based on the lack of evidence.
Yeah.
So here's a list of things that sometimes our patients will come in and they'll specifically ask for some medications, but I do my best to stick with the NIH recommendations as much as possible. If the drugs won't hurt, there are some vitamins and things where you'd say, if they're lacking those vitamins, it's okay to supplement. But as far as dose, sometimes people will ask for extremely high doses that can have side effects and problems.
Yeah, I really think that about 22 months ago, when we didn't know things, like we were all struggling.
Yes.
But right now we have data, what works. So, antibiotic we do use azithromycin and ceftriaxone if they come in with a community-acquired pneumonia on top of COVID-19. But for COVID-19 itself, it has no activity. And recently we've been getting a lot of asks, on ivermectin. And ivermectin, there's some clinical studies that are being done. Outside of that, I don't think we should be prescribing because it really doesn't have any evidence right now to use for COVID-19 patients. So I do really think it's important to stick with what works and what's effective and what's in the NIH guidelines. So I try to stay away from these as well.
Then the vaccine is the best thing we can do to prevent COVID. So I strongly recommend the COVID vaccines to all of my patients that I have in the hospital. But yeah, I don't, as far as the updates go, they do recommend getting a booster for patients.
Yeah. So we'll talk a little bit about boosters, but I'm sure you guys have gotten a ton of booster questions. Pfizer was approved, and recently, initially FDA approved Moderna and Johnson & Johnson, and now ACIP has also approved Moderna and Johnson & Johnson. So patients can get vaccine boosters for those three. They did some data where it also shows if you got Johnson and Johnson initial dose, it might be a better thing to get one of the mRNA vaccines as the booster. So, you have, and also there's some data saying it doesn't matter which booster dose you get, because, let's say you're in a rural community and your pharmacy only has one type of vaccine, and, let's say you got Moderna before, they only have Pfizer now, you can get a booster with Pfizer. So I think that's important to know. You can mix and match, but especially for Johnson and Johnson, data shows it might be better to get the mRNA booster.
We'll talk about this a little bit more in the upcoming slides. And then anti-SARS-CoV-2 monoclonal antibodies. So this is a good thing, and this is post-exposure prophylaxis. So if you have a patient that's has a lot of comorbidities, and they come in and they say, my family has COVID, I don't have any symptoms, but I'm worried about it.
They're not vaccinated, and they could get post-exposure prophylaxis. You have to meet the high. This is a little bit more stricter criteria. But let's say, right, you have a pregnant female who's not vaccinated, and now she's exposed to her kiddo who has, and she's really high risk. She would really benefit from post-exposure prophylaxis so she doesn't develop the infection.
And the pregnancy issues are extremely sad, and they're extremely high. These are high-risk patients. And I don't know if you've seen, I encourage people to read about what's happening in Brazil and what's happened in Brazil with all the pregnant women that have died and their children have died, or the pregnant woman dies and their baby is able to be saved. It's just heartbreaking.
Yeah.
And so I really strongly encourage all the pregnant women to get vaccinated.
I think vaccine is important.
Yeah.
But all these high-risk population, if they get exposed, we as providers should be thinking about, can they benefit from post-exposure prophylaxis? So it's an IM shot, so you give injection, and either one of these monoclonals, and then goal is it'll prevent them from actually developing the infection. So I think this is a really good tool as well.
Mm-hmm. Yeah, it's tough because I never want to look back and say, oh, I wish I gave that patient something that really could have helped. And we've had some patients that have had the vaccine, had the COVID shot, and then they come in a couple months later with COVID. And some of them have been pretty sick. And I look at that and say, wow, that without that COVID shot, I don't think they would be alive.
Yeah.
And so, sometimes, the media may not see it that way. They say, oh, they still got sick. But the way I see it is, they would have gone, and the data supports that they would have done much worse. And many of them would have died had they not gotten the shot. So as far as clinical spectrum of COVID, this is another update in the information on the NIH website, but they talk about opportunistic infections like fungal infections. And so aspergillus is one of the things that, it's post-COVID aspergillus. And this is something that you just have to keep in mind if someone's not doing well, especially if you identify aspergillus in one of the cultures. It's something that we have a low threshold to start voriconazole for those patients.
I've seen fungal infection in COVID-19 patients, especially in ICU setting, right? They've been in the hospital for more than like 10 to 14 days. And they were doing okay, fevers went away, and all of a sudden now they have another fever, right? And that's when you have to think about if they get a pseudomonal pneumonia or fungal pneumonia, so do that workup.
Yes, right. Pseudomonas is the other one that's being seen frequently. And this fungal infection with aspergillosis, it's called CAPA. It's COVID-associated pulmonary aspergillosis. And so you're right, either aspergillus or Pseudomonas are two of the big ones that we have to think about. And then make sure that they're, if they're kind of improving and then all of a sudden they start doing worse, or if they've been on steroids and sometimes an abnormally long time, then that kind of puts them at risk for additional infections. And so we'd want to make sure that if you start an antibiotic at that time, something that covers Pseudomonas, something like Zosyn or Cefepime, and then keep in your mind the association with aspergillus.
Yeah, sometimes what I do is when patients are like really sick and all of a sudden 2 weeks later they crash and they have really,
Yeah.
then I do cover for Pseudomonas and I order all the fungal labs like fungal blood culture, fungal sputum, Fungital, galactomannan from inflammatory markers on the serum. But then I also start them on voriconazole while I wait for those data to come back.
Yeah.
So if a patient is really sick and it's been a long time that they have had COVID, and if your suspicion is high, you could start antifungal and wait for those labs to come back. And I just wanted to kind of show you guys the trend where we are right now. Overall in the US, hospitalization infection curve is coming down. So I think we're getting a little bit of a break right now. Nebraska hospitalization, we're still saying the same, but a lot of other places we're slowly coming down. In Nebraska, we're seeing the infection rates come down overall. But one of my biggest fear, we'll talk about it in another slide, we're just going to be keeping doing up and down until we get people vaccinated.
Yeah.
So, and I really like this graph from CDC. You know, when the first strain came here, the alpha strain, every time somebody got the alpha strain infection, original strain of COVID-19, they infected 2 people, right, on average.
Mm-hmm.
But with Delta, it's just as bad as chickenpox. It's infecting, one person can infect 5 to 8 people. So it's so much more contagious. And when you have Delta variant, your viral load that you carry in your nose and everywhere else is much higher. So you're transmitting it to more people. So that's why it's so important that we get vaccine, because Delta, and you know, it's one of my biggest fear, I don't know how you feel about it, is we're just going to see mutations and new variants if you don't get the infection under control and vaccinate.
Right. Well, yeah, that's exactly how I feel. I think that, you know, the more people that get vaccinated, the better. And it's not just for yourself, because some people will say, oh, I'm young and I'm healthy. I don't really need it. Or, oh, I had COVID. Do I really need the shot? But not only are you helping yourself because you're preventing yourself from getting COVID every few months, and getting either getting sick or not too sick, but spreading it is the other thing. And really you're saving people. And then sometimes people will say, well, if someone else wants to be saved, they should get the shot. But the shot doesn't always work for everybody. So people that are immunosuppressed are, you know, at high risk, and the shot doesn't work because they don't have an immune system that will
not as well.
react.
Doesn't work as well for immunosuppressed, you know, the shot.
Oh, I'm sorry. If they should still get the shot, but it won't work as well. I still recommend they get it, and it will still help. But
I want to share some data on that. One last thing. With the alpha variant, kiddos didn't get a lot of COVID-19 infection, but with Delta, if a state has low vaccine rates, 4 times higher kids getting hospitalized with COVID-19. In our own children's hospital and a lot of other across the states, a lot of kids are getting hospitalized, not just with COVID-19. They're also getting hospitalized with MISC, post multisystemic inflammatory disease in kids, where it affects all their end organs after COVID. So kids are really at high risk for Delta as well now, and hospitalizations have gone up tremendously. I wanted to share some data from state of Nebraska. I really like the way they shared this. So the dark colors are patients who are not vaccinated. So 94%, 92% your risk of if you're not vaccinated, you could get infection. 94% of the people who are getting hospitalized are non-vaccinated. 95% of the people who are dying are not vaccinated. So this is really powerful data from January to September 4th, you know, in our own state, showing that vaccines work. But if you're not vaccinated, you're really, really high risk. And if you look at this graph, and I really like the way they put this here, you guys could see this. This is where Delta showed up in Nebraska. And it's pretty similar to other states too. I just had readily available this data from Nebraska. You can see 6 times more likely to be hospitalized if you're not vaccinated. So the darker color here is vaccinated individuals, but the lighter color is unvaccinated individual, really, really high hospitalization. So, you could see how important vaccines are and how effective they are. So I think these data really nicely illustrate for us.
Right, and even in the patient that have been vaccinated, I sometimes feel like this doesn't show the whole picture because some of those patients are on chemotherapy. They got the vaccine, but they have myelodysplastic syndrome. They're already have so many comorbidities and things that, transplant patients and these patients that I really worry about. All the patients I've seen recently that have died from COVID have not been vaccinated.
Yeah.
And it's a shame, for, death is and then preventable deaths is just something that's really bothers me.
And here is 56% of US population is vaccinated, fully are able to get vaccinated. So that's still really concerning. 50%, like 44% of the population is not vaccinated. So the pandemic is not going to go away anytime soon, unless we could really, really get this communication to our community and get everybody vaccinated. And I really like this graph about here, I get vaccinated, great, I protect myself, but here you go, you have a 5-year-old child who cannot get vaccinated yet. That's why everybody else has to get vaccinated to protect this child. Oh, here is a cancer patient. The vaccine is not effective, so everybody else has to get vaccinated, create a bubble, right? So we really need to do our part. And where I am noticing more and more infections now is in rural areas. And I would really like feedback from all of you how we can help and how we can get the message to rural areas, get increase in vaccination and increase in monoclonal antibody use, because we're seeing a lot of young people get affected now.
Right, and if people say, oh, children, it's a low likelihood, and oh, children do really well. Yes, but the children that died, that could have been prevented.
Yeah.
And
or the 25-year-old that dies that could have been prevented. So I think, it's wonderful that we are able to talk to you all. But if you think we could help more, please let us know, right? And we are happy to come, do more teaching in different areas.
Yes, and all the hospitals that we work with, I think everyone that I talk to really is doing a wonderful job, and it's tough. And right now is a tough time for people in healthcare because we're doing the best we can, and when patients come in and they didn't get vaccinated, and then they have a bad outcome, it's really heartbreaking. And so right now is a really tough time for people in healthcare. So I just wanted to say, that we really appreciate everything everyone's doing right now and in this really tough time.
Yeah, I totally agree. And any way we could help support you guys, you just let us know, especially in the communities. And this one slide just shows that breakthrough infection is going to happen. Any vaccine is not 100%. And we're seeing more and more breakthroughs in immunocompromised, big groups, nursing homes, and also healthcare workers like us, because we get exposed over and over again. So inoculum effect, more you get exposed, higher chances of us having a breakthrough infection. So it's really important. That's why I really like this slide as well. It's from CDC, where they show that the green bar is unvaccinated patients. So 8 times higher fold of getting infected, 25 times higher fold of getting hospitalized, 25 higher fold of dying. The blue bar is you're vaccinated and very low chances of being hospitalized or death. So that's, again, another powerful way to see that vaccines work.
Right, and the media sometimes kind of twists it and they say, oh, you can still get it.
Yeah.
And I actually heard that from a patient right before he got intubated. About a day before he got intubated, he was telling me, you can still get it even if you've been vaccinated. And that's one thing that kind of in the media, that you can still get it, but your viral load's not gonna, go as high. Your likelihood of hospitalization and death is so much lower. And when the viral load doesn't go as high, it also lowers the likelihood that you're going to spread it, as you're saying. So,
and also the inflammation in your lungs. So that's looking at this graph, you could see even if you get it, the chances
Yeah.
of you getting hospitalized and dying is very low compared to not being vaccinated. So I think we just need to continue to emphasize on that. Here's some data why we started giving boosters for immunocompromised, for example. CDC did multiple different studies on Pfizer, and they saw that in immunocompromised patients, patients who are getting like immunosuppressive drugs for like Crohn's and ulcerative colitis, patients who are immunosuppressed getting admitted to the hospital, they all had lower amount of antibody production effectiveness when it came to Pfizer vaccine. So this is one of the big reasons when Pfizer came and said we need a booster. This was one of the big reasons they said we need booster for immunocompromised patients. The next slide will show you all. The dark dots are alpha, red area is delta, and they looked at data from England, Canada, Israel, all over with delta, right? If you look at this last line here, hospitalization and death in all three countries were still prevented by getting the vaccine. So that Pfizer vaccine, for example, in this study still was very effective. So even without Delta or Alpha variant. And I really like this graph. If you guys look at the bottom, the orange is Moderna, blue is Pfizer. As you guys see, the bottom is days. As they reach about 150 days, you see more and more infection. So this was one of the other reasons why now we have booster vaccines. So booster vaccine doesn't mean the vaccine is not working. It's working, but it's nice to get that extra boost to keep those antibody levels nice and high. A patient who has had COVID series, then contract COVID, have to wait to receive a booster shot? Yeah, so let's say a patient has had COVID series, they got COVID-19 infection. They could usually, if it's a mild infection, they could wait 10 days after to get the booster. If it's a severe infection, anything severe is if they're immunosuppressed or they're in the hospital, they should wait about 3 weeks and then they could get the booster shot. So I think that will be your, how to give the booster.
Yeah, that's a great question. And another common question we get is about monoclonal antibody.
Yes.
And if they've received monoclonal antibody, when can they get their shots? And that's a common question we get as well.
Yeah, and for that, you have to unfortunately wait 90 days. So that's the only time that you have to wait 90 days when you get monoclonal antibody, because now we gave you lots of antibodies in your system. So that's going to work for 90 days. And if you give vaccine during that 90 days, it might not be as effective. The only time you have to wait 90 days is when you got monoclonal.
And then one more common question we get, and this is actually a good time, would be the flu shot.
Yes.
Sometimes, when they first came out with the COVID vaccine, they said you had to wait between giving the flu shot and COVID shot, but now they don't say that anymore.
You could get one hand flu, one hand COVID. So it can be done on the same day, same time.
Yeah, and I heard someone just say that to me yesterday. They said, oh, I can't get it for 2 weeks because I just got the flu shot. But, you can go ahead and give it. And that's also what's seen as a missed opportunity.
Yes.
If they're in your clinic and they're getting a flu shot, you can go ahead and give them the COVID shot too. And, because sometimes patients will say, oh, I'll get that in a week or 2 weeks or something, and then you don't see them again. So we don't want to have a missed opportunity. You can give everyone the COVID shot that you can.
Yeah,
Yep.
That's really important. You give both at the same time.
Yep.
And here is what the booster shot is approved now for all three: 65 and older, 18 and you're older living in a long-term care facility, 18 to 49 with underlying medical condition, any type of condition, right? The provider gets to decide that. And high risk occupation, right? Examples are below, but there are a lot of high risk occupations: firefighters, teachers, university professors, daycare workers, food handlers. So anytime you're high risk around lots of other people, definitely get boosters, because then it's not just preventing infection, also it's preserving workforce.
Yeah.
And at a time where we're really struggling to have workforce, it's really important to get boosters so we could all stay and work.
Right, and there's no worry about taking the shot from someone else that needs it. There's more than enough
Oh
shots
yeah,
for everyone. Everyone should be getting it.
there's
Yeah.
plenty of shots. Oh, and I love
Yeah,
this
this is a
slide.
really good one.
So we got a question about natural immunity versus vaccine immunity. Do you want to start?
Sure, yeah, I'll just, well, actually.
Yeah, So like,
Yeah.
you know, this dark little dots over here, right? These are patients that had natural infection. And if you look at the middle red line, that's the median amount of antibodies they have. So if you look at it, when somebody gets an infection, their antibodies, yeah, it's good at 1 month, but around 6 months, it's dropped 10 to the power of 2, really low. It's not that high. It's not there. Over here, if you guys look, this is the patients that have got vaccinated. After the second dose, you know, good, about 1 month. But look at it at 6 months. Their antibody titers are very nice and high. So that's why it's really important. Dr. Horn and I was talking about it, that natural immunity, once you get it, it lasts a little bit and goes away. But when you get vaccines, it lasts a long time, protects you against different variants. Natural immunity, if I get Delta, I'm protected against Delta, but next thing you know, there's a new variant, I can get that. So do we want to get infection every 3 months to get antibodies, or should we be smart and get vaccine, which can protect us against variants and for a long time?
Yes, and so there are some infections that you get and your immunity wanes and then you just get it again. And so the thought is that, you know, people might be getting this over and over again with natural immunity, but if you get the shot, it looks like you're going to be more protected than someone that actually had the virus, as far as getting it again, right? So even if you had COVID, now some people say, well, I had COVID, I don't need the shot. And it's good that they had it and survived it. But if they want to prevent reoccurrence and getting it again, the best thing they can do is get a shot.
Because just like here, if you see, you know, they get Delta, they're good for a month, but their antibody natural levels just drops off. So now they're at higher risk for getting Delta again in 6 months or different variant. So that's why when you guys talk to your patients or to your community, it's really important to say that natural immunity is not staying long enough, but vaccine immunity is lasting longer and protecting against lots of different variants.
Right, and the researchers, when they study this, there's some articles about researchers, the best a person can do would actually be getting COVID and then getting the shots. That is the best protection you can get. And of course, the catch to that is when you get COVID, you have to survive it. And you know, those people that survive it will probably survive it again since they survived it the first time. But that's the thing, the people that survive it, you know, you have to first survive COVID before you can even get to that point.
Even if you have mild COVID-19 infection, we know there's so many post-COVID syndrome, right?
Right, yeah.
Brain fog, depression,
Yes.
You know, myocarditis, clots.
Yeah, that's a really good point. Surviving it is not always the best metric, because we've had plenty of people that come in and they have holes in their lungs, so they have cavitary lesions from the necrosis and all the inflammation that causes that. They come in with brain fog. They come in with all of these chronic issues that if you just look at the one metric that they survived it, you know, it doesn't capture all the misery and all the badness that's happened. So I really like that.
I was looking at a study yesterday. It was showing COVID-19 and why they get brain fog is they're assuming now some animal models, they're actually killing brain cells. COVID-19 is killing brain cells. So like vaccine is the way to go. Anywhere we could communicate this was going to be really, really important. And the last slide we want to leave you with is that, you know, we predict, and this is from COVID tracker data, it just shows that we probably will continue to have in US infection. If you don't wear mask or no mitigation, it'll probably go up again. So, we're going to go see this until January. So we just need to continue to vaccinate and wear masks and be able to prevent. Any questions you all have? You could put it in the chat or unmute and talk to us. Any questions, any concerns, how we could help you?
Well, I think this is a great topic. We will send everybody the PDF of this presentation so you can review it and look at it. And but yeah, no, I think vaccine is the best thing we can do. It really startled me. If you told me, when this first started, that people would not be believing in vaccines.
Yeah.
I mean, I thought we were all very excited. I mean, I was so excited when it came out and to get the shot and everything. To me, it reminds me of Copernicus and people not believing in science and just, to me, I grew up believing in science. I just can't believe it. But
yeah, so vaccine. So takeaway message from this talk would be vaccinate as much vaccines, booster shots. Please give monoclonal antibody in the outpatient setting. And call us with any questions or concerns. And if you think we can help in your community with education, we're happy to do that as well. Thank you so much.
Yep. Thank you very much, everybody.